Welcome. My name is Gabrielle Casper, and I'm honoured to be the president of the International Health Awareness Network, fondly known as IHAN. It is with great pleasure that I'd like to welcome you to the United Nations Commission on the Status of Women 2021 IHAN Virtual Parallel event. The topic we have chosen for this session is climate and COVID's impact on women's health and violence against women. Let me start by introducing you to Dr. Sarosh Roshan. Sarosh is the past president and founder of IHAN.
I am honored also to welcome you all to the parallel event of International Health Awareness Network. And I want to thank our dynamic President Gabrielle and the team for putting such a wonderful program together. The good news is, with the devotion and commitment of the scientists and support of the governments, vaccine has become available. So I would pledge and ask each and every one of you to be the ambassador of information, correct information, and encourage people to get vaccinated. Vaccines are safe and they're going to save lives and livelihood. And I want to take this opportunity to invite you all to join me and celebrate and congratulate and say happy birthday to our dynamic President Gabrielle. Next year, we will celebrate in New York at my home. You're all invited.
Thank you, Sarosh. I'm delighted to introduce Professor Lynn Madden. Lynn is a public health physician and the inaugural Professor of Population and Planetary Health, School of Medicine, Sydney, the University of Notre Dame, Australia.
Thank you very much, Gabrielle, for the invitation to speak. It's a privilege to provide a brief context for the presentations that we will hear. I congratulate IHAN for the initiative of this event. I would like to start by recognising the traditional owners of the land on which I speak, the Gadigal people of the Eora Nation, and recognise their elders past and present. I would also like to recognise the traditional owners of all the lands on which the speakers today present. First, I draw us back to 2019, to the profound drought that affected Australia, and describe the compounding series of public health disasters that have unfolded over the past 18 months from an Australian perspective. 2019 was one of the hottest years on record in Australia. It was also one of the driest years on record. This picture is taken near Lithgow in the Blue Mountains, just behind Sydney, where I'm presenting. We saw rural towns with no water, disruption to agriculture and livelihoods, mass fish deaths in inland rivers. This sustained heat and drought combined to create a flammable landscape and extreme fire weather. This was the result of climate change. This picture was taken also at Lithgow in the Blue Mountains on the 23rd of December 2019. This was part of one of the largest bushfires in Australia's history, a mega blaze that burned for 79 days. It was just one of many fires that burned for 7 months all along the east coast of Australia. There were 33 direct deaths, immense disruption to communities and people's lives, an increase in mental health issues, and over 400 deaths related to air pollution. It was also an ecological catastrophe. The fires were associated with dense smoke haze and hazardous levels of air pollution. This picture on the left was taken coming into land at Sydney Airport on the 31st of December 2019 and shows the air quality and the density of the air pollution. There is no safe level of air pollution. It's estimated that half the Australian population were exposed to levels that were on occasions 12 times hazardous levels. I took this picture from 31,000 feet at that time, and it shows the extent of the smoke haze as it extends right up the east coast of Australia. At places, it's punctuated by the dense mushrooms of the pyrocumulonimbus clouds, where particular foci of the fires were located. Around the same time as the pictures of the bushfires were taken, the first cases of COVID-19 were emerging, which led to the COVID-19 pandemic, resulting in extensive morbidity and mortality. As Dr. Fauci and others have observed, we are creating the conditions for pandemics, including through fueling climate change and driving environmental destruction and degradation. Over the past 18 months, these disasters and other related disasters have been experienced around the world, with an immense impact on the health and life experience of women. Today's speakers and topics explore these clear and present threats. Climate change and COVID-19 are health crises, and they are particular health crises for women. Thank you.
Thank you very much, Professor Madden. Most of you know my passion is women's health and human rights and violence against women. I am not an expert in climate nor COVID-19, so I'm extremely grateful for Lynn's guidance during the preparation of this event. To permit our full program to run smoothly, may I suggest, if you would like to ask questions, could you type them in the chat, and our speakers are happy to answer any questions as they arise. Let us begin by setting the scene.
I am Viji Melnick, Professor Emerita of Biological Sciences and co-president of IHAN. IHAN is a non-profit, non-governmental organization in consultative status with the Economic and Social Council and the Department of Public Information of the United Nations. IHAN was founded by Dr. Sarosh Roshan in 1987 at the culmination of the UN Third World Conference on Women held in Nairobi, Kenya. Dr. Roshan was inspired by the need to focus on the health and education of women, and that remains the purpose of IHAN. Study after study has demonstrated that women's education and empowerment is key to the development of families, societies, and nations. To this end, IHAN works to enhance women's and children's access to education, healthcare, and economic welfare. IHAN has advisory council members in several countries such as South Africa, Kenya, Turkey, Iran, India, and so on. IHAN has conducted international workshops, conferences, and healthcare projects upon the invitation of host countries. These include providing mass immunizations, primary healthcare screening, health and nutritional education, consultation, and care. IHAN has provided educational scholarships to children in South Africa and facilitated the donation of medical devices to countries in need. Some of the major donations were, in fact, arranged by Professor Gabriel Casper. IHAN works closely with select universities and other organizations that have a similar mission on relevant projects and educational activities. IHAN has worked in concert with the United Nations to advocate and implement programs and policies that enhance sustainable peace and issues that affect women caught in conflict zones. In summary, IHAN is dedicated to the cause of empowering women through better health, education, financial independence, and professional advancement. The goal is to provide women with an opportunity to craft policies that benefit their own progress. and be the agents of change for their own lives. We strongly believe that this is the most valuable contribution that we can make for the betterment of not just women, but for all humanity. Thank you very much.
Greetings from Hori Gudalekian, Chair of NGO CSW New York, and from me, Susan O'Malley, Hori's predecessor. What an exciting NGO CSW 65 forum. We planned for 10,000 people to sign up, and suddenly 25,000 people joined, with 900 on the waiting list. I am pleased that the Passable platform has held up. Of course, I am recording this several days before our event. I am honored to be included in such an illustrious list of speakers. Let me talk for a few minutes on how NGO CSW 65 Forum is different from 2 years ago. First, importantly, we have become more global. This year, instead of NGO CSW New York being the planning committee, the 7 NGO CSWs organized the forum. This means that New York, Africa, Asia Pacific, Arab MENA, Geneva, Latin America and Caribbean, and Vienna NGO CSWs met every 2 weeks from the beginning of October to plan the forum. If you went to Consultation Day, you would have experienced how the program moved around the globe. Starting in October, the 7 regional NGOs also worked together as the Advocacy Research Group, which I co-chaired with Erica Higbee for the CSW 65. Agreed conclusion on the priority theme, women's full and effective participation and decision-making in public life, as well as the elimination of violence for achieving gender equality and the empowerment of all women and girls. Following the UN Women's Concept Note, we read and brainstormed together and formulated our demands for the CSW 65 outcome document, which can be found on NGO CSW New York's website. We have even a virtual Vienna cafe where we're meeting with member states. And what about CSW 66? Will it be in person or virtual or a combination? We haven't figured that yet out. Thank you.
My name is Catherine Barraclough and I'm a medical doctor from Melbourne, Australia. I have a particular interest in the intersection between human and environmental health. And today I'll be talking on zoonoses and pandemics, and particularly what they tell us about the need for us to join the dots between humans, animals, and the natural world. So to start very simply with some terminology, a zoonosis is an infection that can be passed from an animal to a human. And what we know is that about 60% of all infectious diseases in humans are zoonotic in origin, as are about 75% of all newly appearing infectious diseases. While fortunately most emerging zoonoses do not cause severe illness or spread rapidly, some obviously can, with potentially enormous impacts on global health and economies. When an infectious disease spreads across countries or continents and affects large numbers of people, it's declared a pandemic. As I'm sure all here will know, the current COVID-19 pandemic is now in nearly 200 countries. It's caused over 2.5 million deaths and really impacted the lives and livelihoods and futures of billions of people. The next point I want to make is that infectious diseases are on the rise. This has been shown in really quite a wide range of studies. What has been recognised from this is that this rise is very closely linked to the really ever-intensifying impact that we humans are having on natural systems. One of the big ticket items that is thought to be behind this rising occurrence of infectious diseases events is deforestation and land use change. So when we clear forests and remove natural habitat, wild animals are displaced and their behaviour is altered. What this does is increase the likelihood of contact between wildlife and people, and therefore the risk of cross-species infection transmission. there is evidence to show that land use change is the largest driver of past emerging infectious diseases events. Another driver is the hunting and trading of wildlife. And again, this is a factor because it increases interaction between wildlife and humans. Wildlife hunting and trade have been linked to numerous zoonotic infections. So HIV and SARS are two that are very well recognised. Livestock practices are also important. So livestock production is the world's largest user of land, and therefore it increases the risk of zoonotic diseases via driving natural habitat loss. Added to this, though, while wild animals are the most common source of emerging infections, livestock often form the bridge between them and humans. As the global population consumes more and more animal products, we are farming more intensively. What this means is large numbers of very similar animals reared together in confined spaces, and this in turn creates ideal opportunity for the rapid spread of infection. And also for different viruses to mix and create new and potentially more infectious viruses. Two examples of infections that have reached humans via farmed animals are bird and swine flu. Climate change is also a major issue with regard to zoonotic disease. So climate has a major influence on the behaviour and movement of many of the organisms that cause infectious diseases, and also on the insect vectors that can help them spread. Lyme disease is one example of an infectious disease that has been influenced by climate change, but there are many others, and there will be more to come. In terms of what we need to think about for the future, it's been said that there are somewhere in the order of 1.67 million viruses that exist on Earth. And of these, over 700,000 that are undiscovered animal viruses that could infect humans. What we need to think about is that really any one of these could be potentially more infectious or more deadly than have infections to date. We absolutely need to improve global infectious disease surveillance and response capacities. We also absolutely need to strengthen healthcare systems and ramp up vaccine and treatment research. But I think at the same time, there is increasing recognition that in the long term, these things will be inadequate to protect health. We also need to look at the primary drivers of disease emergence, which, as I've hopefully shown, really all stem back in some way to the very extreme stress that we are having on natural systems. Without this, we will be forever playing catch up. From, I suppose, conceptually as a doctor, it's very much like treating the symptoms of a disease without addressing the conditions that led to it. So thank you very much to all of you for attending and listening.
Hi, I'm delighted to have the opportunity to speak to you today about the impacts of COVID-19 on women's healthcare from the MSF experience. My name is Claire Fotheringham. I'm an obstetrician and head of the medical unit here in MSF Australia. So it's been just over a year since the World Health Organization declared COVID-19 a pandemic. So looking back at the data from 2020, what impacts can we see on women's health activities in MSF? At the beginning of the pandemic, MSF made a commitment to continue the activities it was currently doing. And that's because we work in areas where there are huge unmet needs and, in fact, chronic emergencies. So stopping to do COVID-19 activities instead would have left huge populations with acute unmet healthcare needs. So our commitment was to continue services going for those needs, to try and protect our staff as much as possible, and in the places where there was the most need or the least ability to manage, to try and add on COVID-19 activities. So this shows antenatal care for 2020. It's very rough and preliminary and not for further dissemination. You can see that there's a decrease in antenatal care that occurs starting in about March, in fact, very profound in May, and then continues to June, at which point it starts to normalise. And this pattern held true across all of our women's health activities. So postnatal care, deliveries, family planning, safe abortion care. We see this drop off between about March and June, and then a normalisation after that. We first saw those initial figures with the declines, we were very worried. We knew that there was a good marker modelling, which showed that a 10% decline in sexual reproductive health services was thought to be likely to lead to about 15 million unintended pregnancies, 3.3 million unsafe abortions, and an extra 1,000 maternal deaths. So we saw declines of almost 20% initially, and we were extremely concerned. What brought it round? I think there were some things that we did, but most things I suspect were out of our control. So certainly our projects really took that commitment to continue services on board and tried to work around it. But in the end, I think a lot of things like the lockdowns didn't continue. The fear of coming to the hospital also reduced when the pandemic turned out not to be quite so bad in most of the places we were working. And there'd also been some closure of hospitals when staff got COVID, and as they reopened, the services also came back online. So what are the consequences from this decline in activities? I think it's very unclear at the moment from the data that we have. We're certainly worried that there were avoidable maternal and fetal deaths during that time, but it's very difficult to tell. We worry that women arrived later and in poorer condition, but that is a problem universally in our projects. So whether it's because of malnutrition, whether it's because of difficulty recognising danger signs, difficulty accessing care, transport issues, etc., we find that women in general often present late and in poor condition. So COVID-19 added an extra barrier, but there were already a lot of barriers to seeking care that existed already. And so how much COVID-19 impacted on top of that is difficult for us to say. We were doing a study in one of our projects on complications of unsafe abortion, which started before the pandemic and paused during the pandemic, but we have tried to adapt it to try and get some data about that. So it may be for the future we will be able to see exactly what the impact of COVID-19 was, but at the moment I'm not really able to say. I think it's important to recognise also that there were significant differences in different projects. So, for example, in the Rohingya refugee camps in Bangladesh, we saw a decline in services, but in fact they've never quite normalised again, and that may relate to ongoing issues with access to care in the refugee camp related to COVID-19. In Africa also in 2020, the pandemic was not as bad as it was first feared it was going to be, and I think that probably impacted a lot of our numbers in terms of not causing such problems. But I think it's also important to recognise that that was 2020. That in fact there is a new wave of COVID in Africa. There have been mutations. You know, the pandemic is not over, and the impacts on women's health are not yet over. And so to look at the 2020 numbers and say, oh look, everything was fine, I think is unrealistic. And in addition, MSF is only one organisation in terms of providing care. Most care in the countries we work in are provided by the Ministry of Health, which has fewer resources and less ability to adapt. And so for them, having to provide COVID-19 services may well have impacted on their ability to provide maternal health care in a way that it didn't impact us quite so much. And so globally, there may well still be quite large consequences from the pandemic, despite the fact that I've presented that we haven't seen so much ourselves. I'd like to touch briefly on sexual violence as well. I separated out because, in fact, almost half of the patients that we see in our sexual violence services are children, and we also see men, so it's not just a women's health activity, although often associated with it. We anticipated, and we've certainly seen evidence that there is an increase in violence associated with lockdowns, particularly intimate partner violence, and yet again we did not see a huge increase associated in our sexual violence activities. In fact, it followed very much the women's health activities reductions in that March to June, and then a rebound or increase afterwards. That might also be because there still is a perception sometimes that intimate partner violence isn't appropriate for a sexual violence service, and I think that's something we need to continually try and address and improve. In addition, some of the adaptations that we trialled, things like using hotlines or telehealth, didn't necessarily work for partners that were in situations of violence where they couldn't have safe access to telephones. And so I think some of the adaptations also weren't that useful. One of the things many of our projects have been doing to try and mitigate the impacts of COVID-19 is trying different strategies and adaptations. So the use of hotlines and telehealth, less useful in sexual violence, but did prove useful in mental health counselling. Also trying to expand into self-managed care, reducing healthcare visits, various different things that we were often already doing prior to the pandemic, but have leaned on more heavily because of reductions in access to care, and are things which we can hopefully use for the future. I just also wanted to touch on vaccination. Obviously, it's not exactly a women's health issue, but I think it's key to recognise that the pandemic still potentially has quite a long way to run in MSF fields, as vaccinations are unlikely to be available immediately, certainly in terms of a mass widespread vaccination. And that means that the impacts aren't just for 2020, but they are ongoing, and we need to remain aware of that ongoing impact on women's health activities while the inability to vaccinate remains. Finally, I can't look back on 2020 without remembering Dashi Bashi Hospital. On May 12, 2020, armed assailants attacked the hospital, killing 24 people, including an MSF midwife, mothers, children. The hospital I've worked in, a hospital I visited, the staff there were incredibly devoted to improving the lives of women and their babies. And unfortunately, due to the inability to guarantee security, MSF pulled services from the hospital. This was in a country at the time that they were also going through their first COVID wave. I want them to know that they are in our hearts and in our minds. Thank you.
I bring you warm greetings from Abuja, Nigeria. Let me start by thanking the International Health Awareness Network for inviting me to speak today, and to thank especially President of IHAN, Professor Gabrielle Kasper, and the founder, Dr. Soros Roshan. I will be speaking today on harmful cultural practices, a global solution. For over 25 years, I have worked with widows who have undergone harmful cultural practices in Nigeria at a time when they are mourning, at a time when they need support and love, at the time when they suffer an added form of violence or grief, where they are forcefully made to leave their homes or dispossessed of their properties, sometimes handed over to the next surviving male in the family. Most of us know another type of violence against women and girls, which is female genital mutilation. WHO has said that we have 200 million women and girls alive today who have undergone female genital mutilation in countries where the practice is prevalent. And they have estimated that 3 million girls are at risk of undergoing female genital mutilation every year. But I want to focus today on a solution. I want to talk about a global treaty to end every form of violence against women and girls, including the cultural practices as I have just spoken about. When you think of it, a global treaty called the Tobacco Treaty has meant that every single place in the world, if you board an aircraft, you will not find smoking. So how is it that we have cultural practices like widowhood practices, female genital mutilation? We have young girls who are married early, who have also become child widows. I have been working with them in the Boko Haram conflict. So why do we need a global treaty? And how will a global treaty work? It will work by prioritizing closing normative and geographical gaps in international law through an innovative narrative and metrics-based approach. The implementation of a treaty will lower rates of violence and reduce costs associated with this very preventable violence. There are proven interventions and approaches. However, these interventions have not been cohesive, they've been patchy, and unless and until we have a global response. So what are the interventions that have been proven to work? These are legal reform, along with framing and accountability measures for the police, where if they are trained either as police, medical professionals, judges, it creates a meaningful pathway for justice. Prevention education for men and boys, women and girls at every level of society will help interrupt cycles of violence in every community. We need access to low or even no cost services for survivors so that we can create a safe space. We need meaningful access to medical and psychosocial care, alongside livelihood support and safe shelters. Data and monitoring is important for these interventions and would increase the efficacy and lead to systemic change for every woman and girl on earth. Nations are advocating for this global call. You and I can add our voices. We can speak up and speak out. Each one of us can be that clear advocate with our heads of government, because it's heads of governments who actually call for treaties. They are the ones that draft treaties, negotiate treaties, ratify treaties. Time has come for us to have a global treaty to end every form of violence against women and girls so that we can unlock the potential of women and girls and unlock centuries of human flourishing. Thank you very much indeed for listening.
I would like to thank Dr. Casper for inviting me to share a bit about my journey as a young woman to leadership within the United Nations system. It's hard to give a start date for my interest or involvement in this work. Through family, it's a field I've always been connected with to some extent. That said, when I finished undergrad at 20, I hadn't quite figured out what to do with myself yet, so I went home to Texas and tried to be useful. One of the first major projects I was involved in was KMAOR, Central American Minor Affidavit of Residency, an Obama-era loophole in the infamously antiquated immigration system. The executive order was an emergency response to thousands of unaccompanied refugee children fleeing to the US from Guatemala, El Salvador, and Honduras. While the Northern Triangle is technically not a war zone, femicide rates routinely exceed those of Afghanistan during the height of US occupation. Furthermore, at least 1/3 of girls and women escaping the socio-political chaos report being sexually assaulted at least once during the months-long journey to the US on foot. Rather than risk this trip, KMAOR allowed children to receive temporary protection in Costa Rica, while their immigration forms were fast-tracked to the State Department. Upon verification, they were flown directly to Miami for medical evaluation and treatment, then to caretakers throughout the US. This program applied to children forced to flee without parents, for example, adolescent girls who feared being abducted, violated, and dismembered for refusing to be the girlfriend of some local criminal or politician, a situation which rarely affords families the time to gather funds to pay a trafficker for more than one person. Due in large part to climate change, the situation has spiraled even further out of control over the last 6 months, as the Atlantic hurricane season has been by far the worst on record. Entire towns have disappeared under the mud, displacing over 5 million people. 2 million are unaccompanied children. Trump ended KMAOR within a week of coming into office. However, Biden, Obama's former vice president, could reactivate the project within a matter of minutes. Given that there are still no legal mechanisms for climate-induced displacement, restarting KMAOR is the most efficient way to get healthcare and expedited legal aid to the 5,000 unaccompanied kids arriving at the Texas border every single week. After KMAOR, I began grad school in New York and my work with IHAN as one of their representatives to the UN. Over the last few years, I've been blessed with the chance to steer a number of projects, including negotiations for the Global Compact on Migration, serving as vice chair of the Working Group on Girls, and now finishing up my term on the executive board of NGO CSW. I'm grateful to have had these exceptional opportunities to learn from the wealth of expertise and experience around me. That said, it's not at all necessary to have a fancy title to do this type of work. To that point, I'd also like to thank Dr. Casper for allowing me to share a bit about a personal project, which my friends and I have recently taken on in Western Sahara. The last colony in Africa, the Sahara region has been a battlefield since the World Wars. Colonialism was, in theory, abolished upon the UN's founding in the 1940s. However, Spain did not begin the paperwork to officially return the territory to its indigenous Sahrawi people until the 1970s, at which point the Kingdom of Morocco launched a new war to colonize the southern tribes, resurrecting ambitions of the Umayyad Caliphate from several centuries prior. It is impossible to cover 5 decades of war crimes in under 5 minutes, so I'll just hit a few highlights. After literally bombing all major cities off the map, the Royal Air Force chased survivors across the Sahara Desert with white phosphorus and napalm. To prevent the refugees' return, the world's largest military wall, the berm, was constructed to accompany the 9 million landmines, which now cover every inch of territory not being actively and illegally exploited for natural resources, as well as land of the Sahrawi sister tribes in Algeria, Mauritania, and southern Morocco. When Spain colonized, this region was called Rio de Oro, River of Gold, but there's also oil, sapphire in every color, at least 70% of the global supply of phosphates necessary for modern agriculture, and some of the world's richest fishing waters. As climate change exacerbates the scarcity of natural resources, the value of the tribe's wealth is increasing exponentially. This was one of the Moroccan monarchy's motivations for rupturing the 30-year ceasefire 4 months ago. Although, as you will see on the next few screens, war crimes have never at any point ever ceased. The next photos are a bit graphic, so if you have a tendency to become squeamish, I invite you to look away and listen in. Throughout the Alawite regime's occupation of Western Sahara, there have been tens of thousands of violations of the human rights to health, dignity, life, and everything else. A few examples from the last month or so, which are too graphic to be shown: an 8-year-old refugee girl dragged out of her classroom by a group of Royal Military Police who stomped her under their boots, molested her, then made her kiss the king's photo repeatedly. This was standard punishment for doodling the flag of her own country. Similarly, a 13-year-old was dragged by her hair from the refugee camp out into open desert, leaving clumps of her scalp in the sand, then violently gang raped. Royal forces eventually allowed a pickup truck to take her to hospital after significant procrastination, but she was refused anesthesia, which is also standard punishment for dissidents. Likewise, a middle school boy who made some mild mark of patriotism was beaten to the point both arms required metal plates to stabilize the fractures, again without anesthetics or sanitation. Within a week, the infection was so severe the plates had to be cut back out of the oozing wounds, still without anesthesia or even pain relievers for after the fact. You're probably wondering why these atrocities haven't been all over the news. On the left is our dear Brahim Saika. In 2016, he was accused of leaking details like the ones you just heard, then subsequently forcibly disappeared and tortured, 2 separate sets of war crimes committed during supposed peacetime. When it became apparent that he would not give up his friends, the occupying forces decided to stab his brains out with a power drill. If I showed you what was happening to people caught snitching on the occupation today, now that the ceasefire is officially over, you would not be able to sleep tonight. On the right are several photos of the Kaya women, for whom March 8th was just declared a national holiday. Several years ago, Sultana had exercised her right to peacefully protest by marching with the flag of Western Sahara. Royal forces bashed her head in with a baton, pinned her down, and gouged her eye out. She literally rode to hospital with her eyeball in her hand, as was dangling from her skull, still attached to the optic nerve bundles at the back. She waited an obscene amount of time to be treated, again without anesthesia, as her injury was nowhere near the worst, and royal hospitals are intentionally deprived of staff, equipment, and electricity. They stitched her eyes shut as a warning to other women. Sultana did eventually receive a prosthesis, but as you can see, that was damaged in the most recent set of attacks, which as of March 8th had escalated to blatant assassination attempts. As of the morning this was recorded, she is still alive, barricaded in the family home with her elderly mother, child, and sister, who still has not received help for the teeth knocked out 3 weeks ago by royal soldiers. Electricity, internet, and all other means of communication have been cut, yet they've brilliantly found a way to live stream their murders if and when that occurs. This way, someone in the outside world will be able to finally seek some form of justice. To that point, I will close with a quick overview of our latest project. We have decided to break with tradition by bringing perpetrators of war crimes to the International Criminal Court before the war is over. The ICC is an independent institution, and though tangentially linked to the UN, they have the authority to establish jurisdiction whenever and wherever they see fit, without regard to the political dynamics which have impeded human rights reporting until this point. Now, we are well aware of the fallen state our world is currently in, so an incredibly brave coalition of healthcare workers, lawyers, and human rights activists are helping us to essentially prepare the ICC's charge sheets for them. Furthermore, everything but identifying information will be made available to the general public at the web page below. We are still in the process of getting everything translated and uploaded. However, the petition for the ICC to immediately initiate prosecution and presumably speed up the peace process is ready to go. Zahara Libre is spelled with a Z, as that is closest to the indigenous pronunciation. On a tangential note, we've also found a way to establish a private hospital where the occupying forces cannot dictate treatment. All that we need now is materials and manpower. We thank you for your time and support.
Greetings, my name is Fedra Fateh. It is an honor to be participating in the 65th session of the Commission on the Status of Women. So what is the status of women after all these years? It is a simple question, but it evokes mixed feelings. Of course, we have made significant progress, but at the same time, it is painfully obvious that our work is not done. Despite all our efforts, by almost every measure, women have not secured equal rights, equal pay, or equal treatment by law or by society. Before COVID, the World Economic Forum predicted that it would take us more than 200 years to close the gender gap. And now, over 1 year into the pandemic, women have borne a disproportionate share of the economic and job loss, as well as the responsibilities of educating our children and caring for our elders. Now the gender gap is even wider. The question is, what should we do now? Do we think it is good to do more of the same? More conferences, more reports, more just best efforts? Or do we need to approach the challenge of gender inequality differently? I'm a lawyer and strategic consultant. In the world of law and business, we set clear goals with rewards and penalties to properly incentivize everyone. I would like to bring a business approach to the problem of gender inequality. Let's look at Starbucks, Apple, or Nike. When they want to increase their revenues, profits, or market share, or launch a new product, they do a comprehensive analysis of the situation, and they come up with a precise plan. That plan has milestones, rewards, and penalties. And when one business initiative or product doesn't perform well, they analyze the failures and come up with a smarter approach. I think of gender equality as a business that has to succeed in the competitive marketplace of ideas. And because I don't think our strategies to date have yielded a sufficient return on investment of time, money, or opportunity costs, I would like to propose a different strategy. Instead of politely asking a world that is run primarily by men to do the right thing and pay us a fair wage and pass laws that treat us equally and have a criminal justice system that considers domestic violence as important as counterterrorism, I think we need to be innovative and disruptive in our approach to gender equality. I would like to target the top of the power pyramid. Let's focus our limited time and energy on winning the top positions in government and in the corporate sector. Let's make change from the top. Last year, I launched the Lady Boss campaign. Our global gender equality initiative aims to inspire and empower girls and women to lead companies and countries. There are 195 heads of state and 500 Fortune Global 500 CEOs. These 695 positions have a disproportionate amount of power. Now there are only 35 women in these top jobs. Men hold the other 660 positions. The goal of the Lady Boss campaign is to achieve gender parity in these top jobs by 2050. So we need 348 women who are willing and capable of leading. If we achieve gender parity in these top jobs, it is a lot easier to achieve equal pay, equal opportunities, and equal treatment under the law. The world would look very different if we were half of the heads of state and half of the CEOs of the most powerful companies. It sounds like a very ambitious goal, but let's consider what this would mean. It isn't easy to win an election and become head of state. It isn't easy to become CEO of a public company. Not everyone is willing to make that sacrifice and personal investment to make it to the top. The analogy that I like to use is the Olympics. Most of us like to be lazy on the weekend and indulge in our favorite sweets. Not everyone is willing to train like an Olympic athlete 10 hours a day for decades. And still, every 4 years, there are approximately 14,000 Olympic athletes. If every country produced only 100 women willing and capable of leading, we would have almost 20,000 women who could be lady bosses. We don't need all 4 billion women to make this sacrifice. We only need 20,000 women. Let's nurture and become those women who are willing and capable of leading from the top. Thank you.
I would like to thank the speakers for their varied and truly thought-provoking presentations. In the chat, I can see there are questions for Eleanor about the global treaty to end violence against women and girls, and she has listed the website for this at everywoman.org. As background for this session, I think we need to have a good understanding of what is health, what is the right to health, and what roles do the Sustainable Development Goals play in women's health. So I will hand over to Victoria, Rayan, and Patrick to brief us on these topics.
Elucidating Women's Right to Health in 2021. Welcome. My name is Victoria Hadlow, and I'm a medical student and a lawyer. Today I will be answering the question, what is the right to health? The right to health is accepted as a fundamental part of our human rights, first articulated in the 1946 Constitution of the World Health Organization and the 1948 Universal Declaration of Human Rights. Today, the most comprehensive article on the right to health in international human rights law is the International Covenant on Economic, Social and Cultural Rights, which was adopted in 1966. It states that the right to health is the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. The right to health is therefore not the same as the right to be healthy, but rather the right to enjoy and realise the highest possible level of health. Australia is party to the core international treaties that establish the right to health. However, the right is not enshrined in Commonwealth legislation. Instead, the international obligations are sustained in laws that fund access to health services, such as to Australia's universal healthcare system known as Medicare. Since the right to health was defined in 1966, key aspects and characteristics of it have been clarified by the UN Committee on Economic, Social and Cultural Rights. It is now accepted that the right is inclusive and extends to the right to underlying determinants of health. The right contains freedoms and entitlements and is closely related to and dependent upon the realization of a number of other human rights. For example, the principles of equality and non-discrimination are fundamental requirements to address social determinants affecting women's enjoyment of the right to health. This is recognized by the Convention on the Elimination of All Forms of Discrimination Against Women, which requires measures to be taken in the field of health to eliminate discrimination against women in order to ensure access to healthcare services. I will now hand over to my colleague who will elucidate on this topic in respect of women in Australia. Thank you for your time.
Hello, my name is Rayan. I'll be discussing the current state of women's health in Australia. Despite making up a little over half of Australia's population, women's access to and experience of healthcare is often inferior to that of their male counterparts. As alluded to by Victoria, discrimination and specifically gender biases in the medical field likely contribute to this disparity. For instance, although cardiovascular disease is one of the foremost causes of mortality and morbidity, irrespective of gender, a study showed that following an acute coronary syndrome, women were less likely to receive coronary angiography, timely revascularization, or the recommended long-term management. Furthermore, and possibly subsequently, women were more likely to suffer major adverse cardiovascular events at 6 months post-discharge. While these findings are already sufficiently distressing, if we look at health outcomes of women in certain minority groups, the figures are arguably more dire. Of particular note is the degree to which we have failed Aboriginal and Torres Strait Islander women. It has been shown time and again that Indigenous women experience poorer health than other Australian women. To exemplify this issue, we can look to the rates of cervical cancer and the associated deaths. The incidence of cervical cancer in Indigenous women is twice that of non-Indigenous women, and appallingly, mortality is 4 times higher in the former group. While the cause of this discrepancy is likely multifactorial, research has shown that at least in part, a lack of cultural safety in healthcare and reduced access contribute to these disconcerting figures. To really encapsulate and reiterate this injustice, data show that in 2011, the median age at death of Indigenous females was approximately 20 years less than that of non-Indigenous females. To conclude, while the issues of gender and racial biases are undoubtedly pervasive and deeply seated in healthcare and policy making, It is important we continue to bring awareness to the issues that prevent Australian women, especially those from minority groups, from attaining their fundamental right to healthcare. Thank you.
Hello, my name is Patrick Dooley and I'm a third year medical student at the University of Melbourne. Today I'm speaking on the Sustainable Development Goals and Women's Health, a pathway towards gender equality. The 17 goals were adopted by all UN member states in 2015. They recognise the integrated nature of inequality, insecurity, discrimination, economy and environment. The ambitious agenda serves as a call to action for countries and communities to achieve sustainable and fair health systems for all people by 2030. All 17 goals have the effect of impacting women's health, and to demonstrate this, I will highlight 3 goals and shed light onto their close relationship with women's health. The third goal aims to ensure the fundamental right of good health and well-being for all people at all ages. Women and girls require health systems which offer comprehensive, safe, supportive, and timely care in times of difficult, urgent need. This goal encompasses the need to further reduce maternal mortality, currently at a rate of 211 maternal deaths per 100,000 live births, and seek universal access to reproductive and sexual health services, many of which were unfortunately suspended during the COVID pandemic due to their classification by some people and organisations as non-essential. Importantly, Target 3D within this goal signals a salient need for strengthening the capacity of all countries for early warning, risk reduction, preparedness and management of national and global health risks, such as the COVID-19 global pandemic. Governments must ensure that reproductive and sexual health services are not disrupted during these crises. The fourth goal seeks to ensure free, equitable and quality education. The cycle of disadvantage and poverty is perpetuated by women and girls being deprived of educational opportunities to empower themselves and develop their health literacy and leadership skills. Girls' access to quality education has been proven to improve their own and their children's health outcomes, and a child whose mother can read is 50% more likely to live past 5 years old. However, the need for quality education extends beyond pupil enrolment to the lack of required resources, infrastructure, and equitable funding to support teachers and education, particularly during a time of technology-supported remote learning. SDG 4 pursues curricular reform and works to reduce violence against girls and women in all settings of learning, be it formal, informal, vocational, and so on. The fifth goal relates to gender equality and is dedicated to empowering women. There are a number of social barriers which prevent women from reaching their full potential. These include gender discrimination, low access to sexual and reproductive health services, violence, early marriage, and female genital mutilation. In particular, violence against women is sadly widespread in all societies, with 1/3 of women having experienced physical or sexual violence, mostly by an intimate partner. Women's voices are further silenced by a lack of representation in leadership roles. As of 2015, only 22% of national parliamentarians were female. Gender equality is intrinsic to women's health and must be ensured at an individual, community, legislative and governmental level. Although some countries were on track to achieving these goals by 2030, due to climate and COVID, progress and achievements have been hindered and often reversed. We know that global health emergencies and our responses to them almost invariably exacerbate the pre-existing inequalities in our communities, including those relating to gender, and often precipitate a rise in gender-based violence. It's essential that we acknowledge the progress already made and the potential for these hard-won achievements to be lost in this climate. We must continue to educate ourselves on the realities of women's health and the long-standing pandemic of violence against women, and continue to advocate and act for urgent change and support. Thank you.
Thank you. The three of you presented beautifully. So now we're ready to tackle our first big topic. With the speakers for climate's impact on women's health, please unmute, say hello, and come to the front of the screen. We look forward to hearing your presentation.
Hello everyone, I am Talia, and this is Olivia, and this is Brittany, and we are medical students from the University of Notre Dame, Sydney, and today we will be giving an overview of climate change and its impact on health. To acclimatise or challenge the change, an overview of climate impact and opportunity for women's health.
So we know that directly climate change will lead to increased environmental hazards, more heat waves, floods, severe storms, and drought, which directly causes injury and death, but can also threaten access to clean air, safe drinking water, food, shelter, and sanitation. So in places where social structures already put women at a disadvantage, these environmental pressures can present additional challenges. So drought, for instance, in many societies, women are socially responsible for the family's water supply. Climate change is projected to increase distances needed to travel for safe water, placing a greater physiological burden on women and may force women to use local, possibly contaminated sources. Women are also more prone to nutritional deficiencies due to increased physiological demand. Climate change can also lead to altered disease patterns. So it's forcing closer proximity of humans and animal populations, and the crossover of habitats is giving rise to zoonotic diseases. So by this, I mean that diseases once only present in animal populations are now transferring to humans. So for example, COVID-19. Climate change is leading to changes in the habitat distribution of disease vectors such as the mosquito. So a shift towards warmer, more tropical climates with increasing seasonal variation will increase mosquito distribution. So for example, malaria, a disease carried by person to person by the female Anopheles mosquito, will become more widespread as the mosquito's habitat area increases. Climate change can also lead to altered human movement and behaviour. So women are largely responsible for caretaking. Increased diseases and a lack of resources leads to increasing demand on women to provide this caring labour, and a decreased time on them investing in their own education and contributing to other aspects of society, notably including decision-making about climate change, amongst other issues. Displacement as regions become more geographically uninhabitable is also leading to environmental refugees. Potential conflict over depleted resources from agricultural insecurity can lead to stress, and that can lead to violence. So following a disaster, it is also more likely that women will be victims of domestic and sexual violence.
Now, let's focus on maternal health. Climate change can worsen environmental hazards that threaten maternal and fetal health. For example, changing weather patterns with more intense and frequent wildfires increase the amount of pollution, dust, and smoke in the air. This can lead to respiratory illness and contribute to low birth weight and prematurity. Pregnant and lactating women, who account for 18 to 20% of the reproductive age population, have increased energy demands. As hurricane intensity and rainfall is expected to increase, food and water supplies are at risk of contamination, increasing the risk of malnutrition. Increased extreme temperature events put pregnant women at risk of dehydration, affecting their renal function, fetal growth, and increasing the risk of preterm birth. Damage to homes, healthcare facilities, and roads from natural disasters decreases access to vital care. Physiological changes make pregnant women more easily detectable among mosquitoes, thus increasing the risk of contracting malaria. Further, an increased frequency in urination at night outside of mosquito nets also increases their exposure. Both physical and mental health is impacted, with greater risk of severe stress after giving birth.
Now let's look at the heart of the issue. Our vulnerability to climate events is not determined by biology alone, but importantly by social rules and responsibilities that differ between men and women. We think of climate change as a universal threat that affects us all equally, but this is not true. On average, disasters kill more women than men, or kill women at a younger age compared to men. In fact, women and children are 14 times more likely to die during a disaster. Women experience disproportionate burden of health consequences of extreme weather events and other climate emergency-related health crises. Despite this, women are significantly underrepresented in decision-making around addressing climate change. Climate change continues to disproportionately affect those who are at the most disadvantaged. In countries where men and women have equal or comparable status, disasters do not disproportionately affect one gender. Therefore, it is imperative, in order not to further widen these health disparities in the most disadvantaged, to acknowledge and address fundamental socio-cultural inequities that amplify these health inequalities.
As a global community, we must respond to this call to action and work towards narrowing the climate change impacts between men and women. We must acknowledge and be sensitive to the gender differences that impact healthcare and health-seeking behaviours. We must include consideration of the barriers which may limit a woman's ability to adapt to a changing climate, such as social norms and power differentials. There is already sufficient evidence to support gender-specific policies on climate change. However, a research gap exists. Further research with sex disaggregated data is needed to better understand the impact of climate change. greater insight into the general and extreme climate-related vulnerabilities faced by women throughout their life cycle will allow us to better understand the impact of climate change and inform climate change policies. We must make a global commitment to acquiring healthcare equity for women that is sustainable with a strong focus on strategies to adapt to and mitigate the effect of climate change. This includes policy that has gender mainstreaming, a commitment to equity in healthcare, and most importantly, women should be heavily involved.
Ultimately, addressing climate change is an opportunity to also address women's health disparities. Will you acclimatise or will you challenge the change? Thank you.
Hi, my name is Chelsea Pereira and I'm a third year medical student from the University of Notre Dame, and today I'm going to speak about air pollution, a silent killer that is causing millions of premature female deaths per year. Globally, the WHO has declared household air pollution as a gender issue. Millions of women, especially those from low-income countries, are unsafely exposed to polluting fuels by cooking on stoves and fires that fill their home with thick smoke. Because of this, women have a significantly increased risk of stroke, heart disease, COPD, and lung cancer, as well as low birth weight in pregnant women. In 2019, I was a part of a team initiative that provided medical aid to the Kalawan community of climate refugees in rural Philippines. Recently, our team conducted a survey that showed that 63% of household occupants were female, reflecting a cultural norm where males would go to the city to work or to be educated, while women would remain to care for household duties. It also found that 90% of households will cook indoors, mostly using kerosene fuel, which is a known noxious air pollutant, with most being unable to afford cleaner sources like electricity. Without adequate waste disposal, 58% of households will burn their waste near their home, which can be seen below, where this young koalan girl is sweeping rubbish into a burning pile, exposing herself to harmful pollutants. To conclude, global action is necessary to provide access to affordable, clean energy, as well. Studies have shown it can halve the risk of COPD in women. Lastly, air pollution is a gender issue, and a social change is critical to ensure women are not unfairly confined to food preparation and the associated air pollution burden. Thank you.
I first met Miss P at a detention centre in Sydney. She was a frail old lady with slurred speech and a resting tremor on her left leg. I wondered why she left her country, seeing as she would inevitably end up in detention. She told me, with tears streaming down her face, that she was forced to leave her beloved country, Somalia, for many reasons. The crops were dry and her family supports gone. She had no choice but to leave as well. Hello, my name is Samira, and today Tina and myself will be talking to you about climate refugees. Miss P's story is not one that can easily be forgotten, but unfortunately it is one that I hear time and time again. Despite Africa's rich resources, a combination of political, natural and economic causes has left it as one of the largest sources of refugees. Climate refugees are now increasing due to climate change. These people are unwillingly forced to leave their homes because of the climate's effects, mainly due to desertification, which leads to famine, poverty and diseases, primarily due to malnutrition. This has had a flow-on effect on society, causing conflict and clashes over the remaining natural resources. Another part of Miss P's story which struck my attention was her health. Like many other refugees, they don't have access to the same rights to healthcare as the citizens of the nations where they fled to. She therefore could not be cared for properly here in Australia. This situation is also seen in my home country of Algeria, which is home to many climate refugees from the rest of the African continent due to its proximity to Europe. Unfortunately, due to racism, many of these refugees are not receiving basic resources for survival, nor do they get treated as equals. The women in particular end up resorting to desperate means of income such as prostitution, which puts their health at further risks. Their lack of access to healthcare means that many of these refugees are suffering from treatable medical conditions and dying unnecessarily. Algerians and their government are still unaccepting of these peoples, as their response has been mass expulsion to neighbouring countries without adequate food and water based on skin colour. Despite efforts from the UNHCR, this problem is still pertinent and requires urgent action from the international community. Last year alone, they expelled more than 16,000 refugees, including children, pregnant women, and asylum seekers of multiple nationalities, without considering the potential risks to their lives and security.
For the next few minutes, I'd like to talk about my homeland, Afghanistan. You may catch glimpses of the atrocities of war that still linger in Afghanistan on television, though you may not be aware of the climate crisis that has been developing for decades. Alongside refugees of war that escape Afghanistan are climate refugees. Floods, droughts, landslides, earthquakes and avalanches displaced millions. The 2019 drought affected more than 2/3 of Afghanistan and reduced family incomes by half in some areas. The drought led to 260,000 Afghan climate refugees and 3.9 million people in need of food and livelihood. This was one natural disaster. In a 9-year period, Afghanistan recorded 496 droughts and 2,245 floodings. So what happens after the dust settles? What happens to the displaced women who find themselves in a new land? My grandmother was one of these women, as was my mother, and the fight for survival never stopped. They found themselves in Iran, where access to healthcare became frugal. Studies show 97% of Iranian women receive antenatal care with pregnancy, compared to an estimated 30% of Afghan refugees. And preterm birth complications and low birth weight prevalence are doubled in Afghan refugees. Unfortunately, this data only reflects legal Afghan refugees in Iran, as the government provides no healthcare or assistance to illegal immigrants, which is anyone who arrived after 2001. Making over 1.5 Afghan women, men and children illegal refugees and denying their rights to healthcare.
Hi, I'm Lauren Gilchrist and this is Emily Harrison. We are talking about the climate crisis facing regional and rural Australia, a spotlight on women's health. Australia is vast, ranking the 6th largest country. Approximately only 1/3 of the population live outside a major city. Living in rural Australia is associated with living a shorter life, having a higher burden of disease and injury, having poorer access to health services, and lower incomes compared to metropolitan areas.
Australia is home to a diverse landscape, from desert to rainforest to vast coastline, and this lends itself to varying climate. Australia has experienced decade-long droughts across the country and cataclysmic climate events, with increased intensity of flooding and bushfires over recent years. It has been predicted that climate change will cause rising temperatures, increased pressures on water supplies and food supplies, longer droughts, more frequent severe flooding and bushfires, and this in turn will have increased social and health consequences, which will be disproportionately affecting rural communities.
The United Nations Framework Convention on Climate Change found that climate change negatively impacts women more commonly, especially those women in poverty. As climate change impacts rural residents more profoundly, it can be deduced that women in rural areas will brunt the greatest burden of climate change. The 3 main topics we will discuss today is women's health, access to services, and improving rural women's outcomes. Rural women are often the protectors of their partners' and families' health, meaning they ignore their own health and well-being to support and nurture their families. The climate change focus in Australia, one is bushfires, where the most recent bushfires devastated the land in 2019. These caused severe smoke inhalation, and this was a major health impact for women. While smoke can affect anyone's health, pregnant women are specifically vulnerable, as this can lead to preterm birth. During this 2019 bushfire, the women reported respiratory-related illnesses at an increased rate of 90% to emergency departments compared to the previous year. As well, violence is associated with bushfires, as after the Black Saturday bushfires in 2009, women living in these areas reported a 7 times likely increase in violence and assault.
Access to services is a challenge in rural communities, and a lack of access, it has a relationship with poorer health outcomes. When we look at rural women, and they have a higher maternal mortality rate, they have higher rates of stillbirth, and they have higher rates of neonatal deaths. And what has been found is that this has been linked to these poorer health outcomes are linked to the lack of access and inadequate services in rural communities. So not only is it limited, it's also under-resourced. So initiatives to improve rural women's health need to be gender inclusive to try and approach the climate change problem. We need to look at networking through social media, community meetings, and even other groups such as gardening. What's been suggested is that we need to empower women through having meaningful education of the relationship between climate change and health and well-being. And finally, we need to encourage female health practitioners to practice in the rural setting. This concludes our talk today, and thank you for listening.
Hello, my name is Francesca and this is Odelia. We're both medical students from the University of Notre Dame, and we will be presenting today on the HPV and cervical screening in rural Philippines, with a thank you for Professor Casper for letting us present today.
From 2019, myself and Francesca have been involved in medical aid work at the Philippines in a small rural village at Calauan, which is now the home to former residents of Manila who were displaced by Typhoon Katsana in 2009. This is a community with severely reduced access to medical care, and therefore they had poor health outcomes. For women in particular, there is a low health literacy regarding fertility, contraception, and sexually transmitted infections. In order to address this, Team Philippines established a bimanual medical clinic in 2013, in which Francesca and I have been involved in.
So how the HPV and cervical cancer screening occurred in the Philippines, or why we did it, was because cervical cancer is the second leading cause of death in Filipino women, and 85% of cervical cancer deaths are in low to middle income countries. In the Philippines, there is no national HPV screening register and no vaccination program. There are issues with poor health literacy, as some women thought that cervical screening was to clean their cervix before pregnancy. There was lack of access to clinics, and there was a high percentage of cervical cancer risk factors. How we performed the cervical screens over there was we started with a bimanual pelvic examination. Then we collected a sample for HPV testing to be analysed in Melbourne, as the laboratories in Melbourne were able to detect HPV 16, 18, and many other strains, to be specific. We then went on to a visual inspection with diluted acetic acid and iodine, which are those pictures on the right, to identify cellular changes. And in conjunction, we provided extensive education on women's health and sexuality.
Of the 615 screens that were successfully completed from 2013 to 2017 in a period of over 9 weeks, with more tests completed in ongoing years, 11% of women had abnormal changes in which 0.5% were diagnosed with cervical cancer. Unfortunately, follow-up was poor for women. However, the women who were diagnosed with cervical cancer and also had a follow-up consult were able to be referred to a hospital in Manila, where radiation, chemotherapy, and surgery were offered. This posed challenges, as the distance to receive treatment can take up to 3 hours, and there were limited financial support from the government. On top of being able to diagnose and give women an opportunity to get referral for treatment, the program was also able to identify many HPV strains, not just the typical 16 and 18, but a wide variety that was not normally seen. Ongoing research is currently being conducted into the prevalence of these different strains in this population.
So the impact of COVID-19 is that this program was unfortunately ceased. This now has caused a lack of preventative healthcare for these women in this area. It highlighted the health system weaknesses in low-income countries, specifically the lack of healthcare workers and laboratories available, so that high-income options that have been deployed during COVID-19, such as self-testing, are simply not viable options in these countries. It highlighted the need for stronger public health and primary care networks, and it pointed out the fact that if an HPV vaccination of 11-year-old girls were to be implemented, it would be the most cost-effective form of prevention, as it is lifelong, as long as it reached 80% of the population. Thank you very much.
Hello, my name's Gillian and I'm a third year medical student from the University of Notre Dame. So by now I hope that my colleagues have shown the undeniable link between climate change and women's health, prosperity and opportunity for safety. I'd like to talk to you now about how we as medical students are advocating for action to be taken against climate change. So first of all, why is it important for medical students to get involved? Well, climate change is undeniably a current and future health issue. This idea was supported by the World Health Organization, who acknowledged climate change to be the greatest threat to global health in the 21st century. This threat comes in different shapes and sizes. It takes the form of heat waves, increasing mortality, air pollution, increasing lung disease, vectors for diseases in more places, more times of the year, and an increased frequency of extreme weather events and natural disasters, which not only cause death, but also raise levels of PTSD and depression. Here in Australia, heat has killed more people than all other natural hazards combined. And last year we were confronted with the devastating bushfires, which are thought to have caused at least 450 excess deaths due to direct injury or air pollution exposure. On top of this, doctors are in an extremely privileged position to generally be viewed by the population as authoritative, trusted, and independent, and can therefore make their voices heard in the calling for change. So, what are medical students doing to have their say? There are two main bodies which oversee student advocacy. These are AMSA and IFMSA. AMSA is the Australian Medical Students Association. They focus on educating medical professionals on the links between climate and health, advocating for medical students' views in the climate health sphere, as well as providing inspiration and opportunities for medical students to upskill and engage in the climate health discussion. The association has published a policy document in which it calls on action from all levels, including the government to publicly declare a climate health emergency and reduce emissions, universities and medical schools to integrate teaching about climate and health into its curriculum, as well as to invest in climate research, and gave recommendations for all other levels to reduce emissions and divest from fossil fuels. Some other AMSA events have included an at-home rally during COVID, and the Greening Hospitals Hackathon, in which students designed ideas to improve the sustainability of hospitals, with the winning idea receiving a grant for their solution to be implemented. Similarly, IFMSA has a climate change listed as one of its key advocacy priorities. They've identified gaps in current medical education, with a survey finding that only 15% of medical schools teach about climate change worldwide, and that in 12% of these programs, they're taught by students and not staff. They also helped to author a paper for the UN Office of Human Rights, reviewing the data on the relationship between climate, both physical as well as mental health. They too have called for interventions on both the government and health sector level. And lastly, students have been taking matters into their own hands by joining the School Strike for Climate Change, with medical students all over the world marching in lab coats and stethoscopes. Thank you for listening. As medical students, we hope to continue to make change both now and into our careers to protect our planet and the vulnerable communities which will be most affected by it.
Again, outstanding presentations on an enormous topic threatening women's health. I can see these talks have generated a lot of questions, and the students have responded with links to sites with the information to provide you with answers. As if climate change has not impacted women's health enough, we now need to deal with COVID-19. COVID-19 is reversing decades of progress in women's health, especially for the world's poorest and most vulnerable. We are keen to hear from the speakers about COVID-19's effect on women's health.
Hi, my name is Dominique Haddad, and today I will be talking about the impact of COVID-19 on the delivery of maternal health care. COVID-19 has caused reduced access to antenatal and peripartum care by up to 50% throughout the globe. Disruptions to maternal health services, increasing social distancing requirements, and increasing economic instability has meant that the delivery and access to quality antenatal care has been significantly reduced. It is expected that the number of stillbirths will increase by up to 25% as a result of the pandemic. The psychological and social impact of this loss will be felt profoundly. Furthermore, routine screening to protect the health of the mother and the fetus will be further compromised if there are reduced and delayed access to essential antenatal care visits. Finally, we must not ignore the mental health of pregnant women. We must ensure that women are culturally and sensitively screened for depression, anxiety, and psychiatric illness. We must ensure that women also feel holistically supported by partners, family, and their community. And we must maintain a state of psychological wellness in the postnatal period. It is essential we remember amidst the pandemic that all pregnant women deserve to feel safe and supported. Thank you.
Hello, my name is Theodore Kouventaris. I will continue to talk about the impact of COVID-19 on women's health with a focus on access to healthcare services. COVID-19 has globally impacted access to women's health services. There's been a decline in access for women and girls to sexual and reproductive health services, antenatal services, safe delivery services, and family planning. These have been disrupted by travel restrictions, interrupted supply chains, stockouts, and overburdened health facilities. The United Nations Population Fund, UNFPA, and Avenue Health conducted an analysis of 115 low and middle income countries in January 21. Due to the COVID-19 pandemic, it is projected that 12 million women could not access modern contraceptives, resulting in an estimated 1.4 million unintended pregnancies during 2020. The UNFPA have continued to invest in women's health across the West and Central Africa region through emergency sexual and reproductive health and emergency obstetric and newborn care. In Uganda, the UNFPA have also created an e-shop which delivers subsidized contraceptives, HIV tests, pregnancy tests, and childbirth kits to the doorsteps of women during lockdown. It is evident through this example that we must continue to find creative solutions in addressing resource allocation in order to improve women's health outcomes. Looking ahead, in the rollout of COVID-19 vaccines, especially to resource-constrained areas, it is imperative that resources are not diverted away from women's health services. Thank you.
My name is Lyra Meehan. I'm a third-year medical student at the University of Notre Dame, and I'm joined with Elise Finch. Today, we're talking about the effects of the COVID-19 pandemic and lockdown on postnatal depression. I'd like to first share a story about Mary, a pregnant woman whose labour was horrifically disrupted by the pandemic and who subsequently suffered postnatal depression. Mary had planned to give birth locally in a small rural hospital. 13 hours into labour, Mary presented at the hospital, but was unable to be admitted due to capacity limits of the COVID-19 pandemic. Plans displaced, Mary and her husband were transferred via ambulance to the next nearest hospital, 100 kilometres away. On arrival, Mary was separated from her husband, once again due to capacity limitations. Mary was alone, scared, exhausted, and now 16 hours into labour, a detail that was lost in the failure to transfer medical records between hospitals. What occurred next was due to undetected low blood sodium, hypernatremia. Now 22 hours into labour, Mary began convulsing and then became unconscious. Still unborn, the baby too began convulsing, tearing its mother from the inside out. Mary began hemorrhaging. Rapidly, her body failed. An emergency caesarean was performed. Mary's labour was grossly impacted by the restrictions of the COVID-19 pandemic. Her trauma subsequently led to her battling with postnatal depression. Postnatal depression is a debilitating and common condition. It can develop up to a year post-birth and have long-lasting effects. Mothers with postnatal depression can suffer from sleep disturbance, anxiety, irritability, obsessions, worry, and suicidal thoughts. Postnatal depression occurs in about 5 to 12.9% of mothers. The prevalence is higher in lower socioeconomic countries. Approximately 50% of women are undiagnosed and untreated. We care about postnatal depression as it's the most prevalent psychological postnatal complication. It impacts the mother and infant bonding and breastfeeding. It also impairs child development and can perpetuate the poverty cycle within a family.
Pandemics are an independent risk factor for anxiety and mood disorders in cross-gender and cross-cultural cohorts. Specific pandemic factors that cause mental distress include quarantine or social isolation periods and social distancing, which cause fear, social isolation, and frustration, and increased exposure to pandemic content on social media, which consistently increases psychological distress. Internationally, rates of postnatal depression have risen dramatically in response to COVID-19 as a result of healthcare measures to reduce exposure, including fewer antenatal appointments and early discharge, which have reduced early intervention and peer support opportunities. Further, fear of maternal transmission of infection causes an increase in reported depressive symptoms. Finally, the pandemic has increased unemployment internationally, causing increased psychological distress, reduced confidence, and a lack of self-efficacy in parenting skills. In response to COVID-19, UK mothers with clinically significant depression increased by 15%. Depressive symptoms in Canadian mothers increased by 26%. UK mothers reported less postnatal support. Polish mothers reported an increase in severity of depressive symptoms. Rates of perinatal depression increased by 15% in China, and high levels of perinatal distress were reported in women in Pakistan. In summary, COVID-19 has caused an increase in postnatal depression internationally. Long-term physical and psychological outcomes are yet to be understood, and this requires longitudinal research to assess development and health of those impacted. Finally, evaluation of services offered during the pandemic is required to prepare for future pandemics. Thank you.
Hi, my name is Rafael Geni, and I've got with me Dilini and Balana. We are both third-year medical students at the University of Notre Dame, and we're here to talk about how COVID worsened precarity for refugee women. A little bit about my story. I'm a refugee from Iraq, and I migrated to Australia in 2012, and I'm privileged to have basic necessities of life, safety, adequate education, and live in a country that follows strict measures to control COVID. This is compared to one woman back in my home country who had to flee their homes because of ISIS and are currently living in very crowded camps, spending their day lining for food and water. Refugee intake during COVID is the lowest it has been in 2 decades. In 2020, of the 1.44 million refugees in urgent need of resettlement, only 22,770 were resettled through UNHCR. Many refugees have been unable to continue their language classes because of COVID lockdown. Some of them had to transition to online learning, and this has been a new struggle to them, as many of refugee women do not have access to computers and internet connection at home or have a quiet study environment. In terms of employment, refugee women have been particularly affected by COVID. This is because most of these women work in sectors that have been most affected by COVID, for example, hospitality and cleaning services. In terms of job opportunities, refugee women generally have low job opportunities. This is because of language barriers, low education attainment, and lack of previous job experiences in their home country. And now, given the slack in labour market caused by COVID, refugee women have rarely any chance to obtain employment.
COVID-19 has heightened the vulnerabilities of refugee women who are known to be at increased risk of intimate partner violence, physical harm such as sexual and reproductive coercion, psychological and financial abuse, which are all exacerbated during lockdowns as they become even more isolated from their community and other support systems. Risk factors have been linked to immigration status, particularly spousal and sponsorship visas, abusive partners who may use the family law system to intimidate their partners when they have more advanced English language skills and knowledge in the legal processes, and reluctance to report violence due to fear of authorities and concerns about the severity of consequences. COVID-19 has exacerbated the barriers of healthcare access for refugee women as the agencies that normally serve refugees have become financially strained. The lack of face-to-face consultations often discriminate against women who have limited English and limited access to online platforms. The risk of COVID-19 is further amplified for refugee women living in camps and settlements where physical distancing is near impossible and healthcare services are already overstretched. The goals moving forward are to incorporate integrated trauma-informed care delivered by health professionals in their native language and with health interpreters. In a COVID-19 safe manner, reconnect these women to peer support groups, ensure accessibility of COVID-19 vaccinations for refugee women in their respective migrated country or refugee camp, and free services for learning English and skills that would increase their chances of employment. Refugees have the same hopes and ambitions as us, except with a twist of fate has bound their lives to a global refugee crisis on an unprecedented scale. And as this world heals from COVID-19, no refugee women should be left behind. Thank you.
Hello, my name is Georgina. I'm Josie. And I'm Lily. Today we are honoured and eager to talk to you all about the impacts of COVID-19 on young girls. Currently, the world is home to 900 million adolescent girls. A significant proportion of these women will sadly be subjected to particular disadvantages because of their gender and young girls because of their age. And whilst the world and society are improving the rights for women, COVID-19 has come at a particularly sensitive time of change, stunting the progression we have fought for and failing young girls worldwide.
The outbreak of COVID-19 has resulted in many job losses, with over 25 million people globally out of work. With increased economic strain and basic necessities no longer assured, families are forced to abandon education, particularly for their daughters. A community leader from Nigeria explains this harsh reality, stating, "If there is money, we further their education, but if there is none, then we marry them out." For women in these developing countries, there is simply no choice. Once strain is placed on the family, their education is first to be disposed of. When the COVID-19 pandemic hit, us three girls, all in different stages of our education, never had to worry. Our education was never second-guessed, never ignored, and never dismissed as not important enough. But this was not the case for all young girls. UNESCO estimates 111 million girls living in low-income settings are currently out of school because of COVID-19. Whilst there was a rapid expansion and transition to online learning during the pandemic, this was dependent on accessibility to technology and the internet. Even if there was accessibility, boys were given priority. Boys are 1.5 times more likely to own a phone than girls in developing countries, and are 1.8 times more likely to have access to the internet. As these girls are taken out of school and kept at home, their responsibility increases in the household, and their education is not valued as highly when compared to their male counterparts. They are faced with a biased expectation of contribution to the family through domestic chores, care for siblings and elderly, and to start income-earning activities. This may not necessarily be a secure or safe job for girls of this age, and due to their lack of education, they may be subjected to low-paid work such as manual labour or sex prostitution. Due to this, the pandemic actually threatens to completely cease these girls' entire education, potentially putting 20 million more girls around the world out of school permanently, creating lifelong disadvantage.
While many parents are pulling at straws in order to maintain a pre-COVID lifestyle, desperation for financial stability is more commonly than not resulting in young girls becoming involved in child marriages, sex trafficking, and prostitution, more likely than not without consent. The term child marriage identifies such marriages that take place before the age of 18. However, unfortunately, this is not the whole story. Within the developing world, 1 in 3 girls are married before their 18th birthday, and a horrific 1 in 9 are married before they are 15, the average legal age of consent globally. These girls have been stripped of their childhood and education, exposed to high-risk pregnancies, domestic violence, and placed in a perpetuating loop of poverty and sexual and emotional trauma as a result of these child marriages. While the severe prevalence of child brides was already a grave humanitarian emergency, after a decade of efforts, we have successfully decreased the amount of child brides by 15%. However, UNICEF estimates that within this decade alone, there will be an additional 10 million child marriages as a result of the pandemic. Similarly to child marriages, selling your child off due to financial stress is not new, and COVID heightens the likelihood of this behaviour to occur. Sex workers are among the most marginalised people in the world, often facing human rights violations, harassment, arrests, and lack of access to basic health and social services. According to the UN, an estimated 25 million people worldwide are victims of labour and sex trafficking. Children make up 1/3 of trafficking victims, with girls mainly exploited for sex. The ongoing impacts that young girls are faced with is extensive, including susceptibility to sexually transmitted diseases, reproductive cancers, unintended pregnancies, domestic abuse, post-traumatic stress, and other mental illnesses. With the incidences of child marriages and transactional sex rising, the COVID-19 pandemic has indirectly exposed adolescent girls to multiple sexual health risks, such as unplanned pregnancy and sexually transmitted infections. A diagnosis of an STI means a lifelong need of medical support, as well as a certain stigma attached to that individual. And an unintended pregnancy causes mass physical and psychological implications that cannot be underestimated. Specifically, pregnancies further prevent young girls from recommencing their education, with the stigma associated causing many schools to ban physically pregnant girls from re-enrolling into school. In some cases, it has been seen that large proportions of adolescent girls were not allowed to return, irrespective of their pregnancy status, further exacerbating gender disparities in education and depriving millions of girls from their education and potential future.
The concept of staying home and saving lives was a message used by governments across the globe in order to flatten the curve. However, this has brought along unintentional social consequences where domestic violence became more prevalent among households and was unknowingly left to thrive. The World Health Organization estimates that 1 in 3 women have been subjected to intimate partner violence, and within the last year alone, 243 million women aged between 15 and 49 have been involved in abusive domestic environments. With unemployment, isolation, and financial stress rising, a rise in domestic abuse feels inevitable. However, pathways of protection such as childcare providers, mandated reporters, and women's homes, which would normally provide a safety net and support for victims, are now forced to close their doors. No matter the form of abuse, it can have incredibly negative impacts on children that grow up in these environments. This leads to young girls who were victims of domestic abuse becoming more vulnerable to engaging in toxic relationships within their adult life, perpetuating the cycle of abuse. After fighting for so long to allow these girls the opportunity to engage in education, we need to make sure that all that is not lost in this pandemic so that young girls can continue on with their education, receive economic empowerment and social protection. Thank you for giving us the opportunity to shed light on this important issue. Whilst we have discussed many injustices young girls are faced with, this is merely just the beginning. Please scan in the QR code to be redirected to sites for further information and help hotlines.
Hi, my name is Caroline, and today I'll be discussing the impact of COVID-19 on women's health and the subsequent demands on architecture to adapt in these unprecedented times. As noted in the United Nations policy brief detailing the impact of COVID-19 on women, it has been highlighted that the pandemic has had a disproportionate impact on women's health and security. Globally, the number of women and girls subjected to sexual and/or physical violence has been exacerbated since the outbreak of COVID-19, and the statistics displayed on the slide are devastating. Additionally, women between 25 and 34 are 25% more likely than men to live in extreme poverty, an issue which is further fueled by the lack of job security in light of the pandemic. With increased strains on women's health and security perpetuated by COVID-19, women's places of refuge have been significantly impacted. Unfortunately, places of refuge in low socioeconomic countries have been at the brunt of this issue due to the degradation of pre-existing infrastructure, lack of funding, and necessary resources. The limited accommodation provided from these shelters, as well as the risk of exposure to COVID-19, has brought to light the need for immediate change and architectural adaptations. Already, measures have been put in place, including a number of countries designating domestic violence shelters as essential services. Subsequently, this allowed for greater efforts and resources to expand the capacity of these shelters. Additionally, organisations such as Architects Without Frontiers have been able to work with locally sourced sustainable resources to build a number of refuge centres, including the ones shown on the slide. The organisation has both repurposed pre-existing architecture and designed new spaces to maximise security and hygiene, a sustainable step in the right direction. Hope House is one example of the work achieved by Architects Without Frontiers. The building is a hybrid of multiple programs and facilitates not only safe housing, yet education centres, recreation and sporting facilities, as well as produce gardens. Whilst progress has been made by small-scale organisations, there is still a considerable way to go, and more ambitious measures partnered with increased funding is certainly required. Thank you.
Thank you for these fabulously researched presentations. It is very sad to hear about COVID-19's impact on women's and girls' health, and fascinating to learn about the changes in architecture needed to support our new COVID lifestyle. Our next speakers will present on the horrific topic of violence against women. Please could the speakers unmute and come to the front of the gallery of faces. For many years, Professor Suzanne Stutman has played a substantial role in IHAN, and we have asked 13-year-old Maya from the Dominican Republic to start this session by reciting one of Suzanne's poems.
My name is Maya Manson. I am 13 years old and I am a student at the Science High School, Liceo Científico Dr. Miguel Canela Lázaro in Dominican Republic. I would like to read a poem called A Prayer of the Girl Child, written by Professor Suzanne Stutman. When I grow up, please let me be safe. Learn to read and write. Live with my parents and my brothers and sisters. Not be sold to work as an indentured servant or a sex slave. Have enough food and clean water to enable me to have a healthy body and mind. Keep my sexual organs intact and not mutilated. Allowed to love and marry the person of my choice. And able to keep the children that I bear and to bear as many as I choose. When I grow up, may I discover a world populated by all who honor peace in one another. When I grow up, may we all be as one. Thank you.
Good morning, my name's Hannah and I'm a third year medical student at the University of Notre Dame, Australia. And today I'll be presenting alongside my fellow students, Danielle and Sam, on the shadow pandemic, addressing the rise of violence against women and girls in the COVID-19 era. To begin, in the early months of 2020, as COVID-19 swept across the globe, governments struggled to contain the virus, instituting restricted movement, travel bans, and compulsory stay-at-home orders, all with very little warning. As we sheltered in our homes, socially distanced and safe from the virus, sadly, for many women and girls, these measures brought them closer to a danger hidden behind the doors of their own homes. Defined in 1993 by the UN as any act of gender-based violence that results in or is likely to result in physical, sexual, or mental harm or suffering to women, domestic violence is one of the greatest violations to human rights. It has now been recognised by media outlets and governments around the world that the living conditions and restrictions, combined with soaring unemployment rates, financial instability, and the global increase in stress and anxiety, has made the perfect storm for a rise in domestic violence, a health crisis described by the UN as a COVID-19 shadow pandemic. In fact, as early as February of last year, there were reports from China of a threefold rise in domestic violence incidents. Similarly, France reported a 36% rise in domestic abuse complaints. American states reported an increase that ranged from 20 to 35%, and in the UK, the National Domestic Abuse Hotline experienced a 25% increase with the introduction of strict stay-at-home orders. While these early trends could not provide strong evidence for what the trend would be across lockdowns, a systematic review and meta-analysis published on March 9 of this year has confirmed the incidence of domestic violence rose significantly in the period of international lockdown. This trend was despite the unfortunate reality that even before COVID-19, up to 40% of women who experience domestic violence do not report it. With reduced support networks, outside observers, and time away from partners to report abuse, there is strong grounds to believe that even this data is an underrepresentation of the true numbers.
So what's been done about this? Well, it's encouraging to see that there's been a global recognition of this increase in domestic violence, and multiple countries have tried to address this. For example, in Canada, domestic violence shelters remained open during lockdown. In Italy, prosecutors have ruled that in situations of domestic violence, it's the perpetrator that must leave the family home instead of the survivor. In France and other countries, including the Caribbean, alternative accommodation has been provided as shelters exceed capacity. In China, the hashtag anti-domestic violence during epidemic has been used to bring public awareness and provide links to resources. Finally, Australia, Canada, France, and the UK have increased their funding to support women experiencing violence, as well as organisations providing services. And there's also many more. Nonetheless, it's important to highlight that the pandemic has caused resources and services to be stretched incredibly thin. Consequently, the creative and innovative solutions has been needed to address this. And we've seen such solutions being developed globally. For example, pharmacies and grocery stores in France and Spain have introduced code words to help enable women to indicate that they're in trouble and need support. In the UK, police have enlisted postal workers and delivery drivers to look out for signs of domestic violence. UK app developers have also created Bright Sky, which is basically an app that provides support and information to survivors, but can also be disguised so that people worried about their partners checking their phones can feel safe. Several countries have also attempted to ensure that the justice system can continue to operate via virtual means, such as having domestic survivor teleconferences into court proceedings. And finally, with all these great innovations and increased need for support and services, UN Women is providing up-to-date information and supporting vital programs globally.
Despite these adaptations and innovative solutions, further work is needed due to increasing demand for funding and services as the pandemic continues. As such, I'm going to discuss 5 main areas where these ongoing needs can be addressed. Firstly, support services. Greater availability and capacity of health, justice and support services by facilitating online transitions is needed, for example, with online counselling or the virtual justice system, ensuring that these services remain essential and facilitating equitable access to the internet and other resources for all women, including those of rural and low socioeconomic status groups. However, not all women may feel safe to use online services at home. Thus, it's important to ensure services are available outside the home. Modelling what was done in France, Spain and the UK, training essential workers who will come into contact with survivors of domestic violence outside their homes to recognise, respond to and direct them to available services is also needed. Secondly, with policy and planning, survivors of domestic violence must have a key role in developing policy changes and recovery plans, ensuring that domestic violence remains a prioritised issue addressed by government bodies during the pandemic. Within these recovery plans, governments should address risk factors for domestic violence exacerbated by COVID-19, including unemployment and isolation. Thirdly, we need to be scaling up public awareness campaigns. For example, the United Nations Women's Shadow Pandemic Campaign across multiple communities and languages via online and offline means. We need to ensure that we're collecting data to better understand the impact of COVID-19 on domestic violence and how effectively we are adapting with our services, which will inform our ongoing response. Finally, for future, addressing the social barriers within communities that impact women's access to support and investing in long-term preventive measures will help address domestic violence in the aftermath of this pandemic and for similar situations in future. If we can address these domains by working together as a global community, then we'll be on our way to fighting this shadow pandemic.
Thank you.
Hello, my name is Anaith Au and I'm a third-year medical student from the University of Notre Dame, and today my talk is on violence in the times of war climate. The climate in which women find themselves is intricately linked to gender-based violence, especially a war climate. War destroys structure. It creates an environment that is conducive to a breakdown of law enforcement, social networks, and a scarcity of basic provisions and needs. Amongst all of this, it allows war crimes to be committed with impunity and no accountability for perpetrators. The latest example of such atrocities can be seen in the world's newest nation, South Sudan. In a report by the Global Women's Institute, 33% of women and girls experience sexual violence by a non-partner. 33%. The UN Commission on the Human Rights in South Sudan intimated that sexual and gender-based violence remained the central feature of conflict in South Sudan. During the recent civil war, a group of South Sudanese women fetching water were raped by soldiers from the National Army. The government lionized and imbued rape as compensation for the soldiers' work, thereby framing rape as a reward and not as a dehumanizing act. In the climate of war, the ramifications for women remain long after the abhorrent ordeal. Many women find themselves within refugee camps and unable to leave due to the constant fear that someone would attack them. Fear of life and fear of choice as a consequence of gender-based violence is psychologically debilitating, worsened with no redress for the victims. Violence against women is a public health issue because when women around the world are raped trying to support their families, that is a problem. When the burden of violence has worse health outcomes then hypertension, smoking, and obesity, that is a problem. And finally, when violence against women is described as a reward for being in the army, that is a problem, and consequently becomes our problem too. Thank you.
Hi, my name is Georgina Harris, and today I will be discussing the importance and impact of social media use for women during the COVID-19 lockdown period. During the COVID-19 lockdown period, social media rapidly became a crucial communication tool for information generation, dissemination, and consumption. Digital 2020 July Global StatShot report reveals that 3.96 billion people use social media today, accounting for around 51% of the global population. More specifically, in Australia, 71% of the population actively use social media. Facebook reported that messaging was up by more than 50% on its platforms as a result of the lockdown period, and that people were spending 70% more time across these apps, while group calls were up a staggering 1,000% in March. While social media saw a significant rise, devastatingly, so too did the instances of domestic violence. Throughout the COVID-19 lockdown period, domestic violence emerged as the shadow pandemic. Early reports have documented alarming rates of increases in domestic violence around the world, with reports ranging from a 20 to 25% increase in calls to helplines in Spain, Cyprus, and the UK, to a 40 to 50% increase in calls in Brazil. Peterman et al. 2020 documented similar increases in Australia, China, and the United States. It was reported in Australia that at least 11 women died from domestic violence-related incidences since COVID restrictions were imposed in March. It was in this period of lockdown that the desire for community connection and support erupted, most specifically on the social networking app TikTok, which was the second most downloaded app in Australia last year after Zoom. During the lockdown period, aside from dancing, lip sync videos, and cooking videos, TikTok provided a platform for information sharing and support. More specifically, the launch of the Signal for Help initiative by the Women's Funding Network. It was launched as a safe way for domestic violence victims to reach out to others in a non-verbal way. The initiative was first launched in Canada, then in the US, and then went viral on social media. Other initiatives included calling 999, coughing, and then pressing 55, which lets operators know that it's not safe to talk. There was also the suggestion of how to secretly call the police under the guise of ordering a pizza. These TikTok initiatives were not without their shortcomings. While education on domestic violence was positive, messages needed to be conveyed in a safe manner, and that these messages were conveyed safely for the victim and for the person being asked to receive or support or give a response. In addition to the efforts on TikTok, Google and Facebook partnered with UN Women to make information and resources available for survivors of violence. Google provided ad grants valued up to $1 million USD to UN Women through the Ads Grants Crisis Relief Program to promote content on COVID-19 and gender equality in 2020. Facebook made resources for survivors of domestic violence easily and quickly available through its platform. These resources included tips on how to recognize signs of domestic abuse, how to help someone you suspect might be experiencing domestic abuse, and how to keep yourself safe. Twitter also provided a tailored service, which meant that Twitter users who searched for terms associated with violence against women, at the top of the search result would be a notification in their local language, followed by a relevant hotline number and a Twitter handle for that service. It is important to highlight that the lockdown period for COVID-19 has not created new problems for women, it has just exacerbated existing issues. And it has been through the use of social media that many have found support, guidance, and a sense of community around some of these issues, which has in turn highlighted the importance of social media during the period of COVID-19 lockdown. Thank you.
Hi everyone, My name's Isabel Payne and I'm a third year medical student at the University of Notre Dame and the University of Notre Dame's approach in educating medical students on this area. So violence against women is recognised by the UN as any act of gender-based violence that causes or could cause physical, sexual or psychological harm or suffering to women, including threats of harm or coercion in public or private life. This definition makes it clear that violence against women may take a number of forms, and so as a result may become difficult to recognise and thus intervene. In Australia specifically, violence is experienced by both men and women. However, there are distinct gendered patterns of violence, with women being most greatly affected. In Australia, intimate partner violence is the greatest health risk factor for women aged 25 to 44, and on average, 1 woman a week is murdered by her current or former partner. These rates are almost 3 times as high among Aboriginal and Torres Strait Islander women and have increased for the female population as a whole due to the COVID-19 pandemic. So these rates are really shocking and highlight how much work needs to be done in our society to target this issue. Healthcare professionals, particularly general practitioners, are often the first people to whom women will disclose episodes of violence. Studies have shown that full-time GPs are seeing up to 5 women per week who have experienced some form of intimate partner violence. It's therefore crucial that medical professionals are equipped with the skills to recognise identifiers of violence in their patients and discuss these appropriately and safely. Women experiencing violence should feel that they can go to doctors for help and that they will be believed and cared for.
Thank you for these excellent presentations. Conflict, climate and COVID has made the perfect storm for a rise in violence against women and girls. A health crisis described by the United Nations as the COVID-19 shadow pandemic. Prof. Madden, would you be happy to share your thoughts arising from our presentations on climate, COVID, and women's health?
Thank you, Gabriel. The presenters have described how, if you bring new stressors into communities, it highlights and exacerbates the existing inequalities in society. Gender and climate change, air pollution, and COVID-19 are social determinants of health. By definition, these are socially constructed. They are created by society. They arise from the way we organise society, its structures, processes, and institutions. They reflect the power imbalances in society. As the speakers have described, it also means that society can do something about it. IHAN is to be congratulated for being a focus for maintaining awareness and education about these issues. They are to be congratulated for identifying action and creating a constituency to support this action. This is an essential community of practice. We are all in positions of power, and it is important that we use this power and the disruption caused by COVID-19 to build back better and urgently. Well done, Gabriel, your colleagues, and all the presenters today. Next year, we continue this essential dialogue with a focus on climate change. Thank you.
Thank you, Professor Madden. And what can we do? It is important that NGOs and academic institutions continue to advocate, educate, and collaborate to assist women across the globe. On behalf of the International Health Awareness Network, I would like to thank our speakers and the participants attending this parallel event. It gives me great comfort to know our future is in your hands. Thank you.